Good afternoon, and welcome to our webinar entitled Ask Me Anything, Collaborative Practice Agreements and Protocols, supported by the ACCP Immunology and Transplantation PRN, as well as the American Society of Transplant Pharmacy COP. My name is Kristen Belfield. I'm a clinical pharmacy specialist in solid organ transplant at Yale New Haven Hospital, and it's a pleasure to moderate alongside Staci Serluco. She's a solid organ transplant pharmacy specialist at Children's Healthcare of Atlanta. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality on the left-hand side of your screen and send the question to the presenter group. We will take questions at the completion of the presentation. There will be an evaluation for this webinar available at its conclusion. We encourage you to complete this to let us know how we did today and how we can improve our webinars going forward. The slides from today's presentation will be posted to the ACCP website in the section titled Webinar Slides after the presentation. If you experience any technical difficulties during this webinar that are not fixed by logging out and just refreshing your internet connection, please make the presenters aware through the chat functionality. There is also a live chat on the upper right-hand corner of the screen where you can get live technical support from any meeting. Without further ado, I'll turn it over to our panelists for their introductions.
Oh. Okay. Hi, everyone. My name is Jillian Casale. I am a transplant clinical pharmacy specialist practicing at the University of Maryland Medical Center in Baltimore, Maryland. I am in a large group of clinical specialists, and we have a very robust collaborative practice agreement. And my day-to-day work includes rounding with the multidisciplinary team on nearly all organ transplants house-wide, as well as some patients in select clinics in the ambulatory setting where our collaborative practice agreement extends to. And if I were to say what I love most about my role, I think the thing that I come back to time and time again is that I love that one moment of my day I am rounding with the team, discussing really high-level complex plans about these really complex patients, and the next moment I have to go into that patient's room and boil down those terms into a language they can understand. And I just really like that the transplant pharmacist is involved in really all aspects of their care through that way.
Laura, I think you're on mute.
I guess while Laura is figuring out her mic, I can introduce myself. My name is Janice. I am a pharmacist at UC San Diego here in California. My official position is the clinical pharmacist in abdominal transplant. Personally, I only do outpatient clinics, and this includes kidney, liver, and then a new clinic we started for transplant diabetic patients. However, I do have colleagues that work on the inpatient setting, and we have collaborative practices throughout all phases of care. One-liner, oh my goodness. I have a lot of responsibility. Day to day, I do teaching with the students. We see patients in clinic, basically 8 out of the 10 clinic days. And I do refill requests. I enter inbox messages. I do drug information questions. There's a lot of things to do from day to day. But what do I love most about my job? I think it's a teaching aspect, and that includes teaching, the patients and the caregivers, also my colleagues. I like teaching them clinical pearls, basically from day to day, something they didn't know about already. And then I think the actual thing I like the best about my job is seeing our patients recover. So they go from, MELD of 40 plus, they're discharged, a few weeks later, and then we see them, they're fully recovered several months later, back at their job or school. Those are the many different things I like about my job.
We have the majority of their
Hello, my name is Margaret Jorgenson. I work at UW Health in Madison, Wisconsin, and
right.
I'm part of the abdominal solid organ transplant team. But I think specifically for this discussion, we were talking about a collaborative practice agreement, and we do have this new sort of stewardship initiative specifically for CMV.
Austin can speak to this more.
And
looked at BGP in the past.
Sorry, I had some background noise. Hang on. All right, this is Jillian Fose. We seem to have lost May, so I will jump in. I'm also at the UW and a clinical pharmacist in solid organ transplant. May is going to be talking about our CMV stewardship clinic, which she and I got going as a residency project. And then I'm going to be talking more about our anemia collaborative practice agreement, which we have in the outpatient setting. We both work on the inpatient and outpatient setting, caring for abdominal transplant recipients. So we do all the things that other abdominal transplant pharmacists do. And then what do I love most about my role? And I would say the ability to directly impact patient care. So through our collaborative practice agreements, we get to make decisions independently, within obviously the scope of the CPA. But I like to be able to do that and then see how that impacts patients' care and quality of life. So this is Jillian again. Since Laura seems to be interrupted, we'll just jump into the first question, I guess. And so this question was, can you describe the development and approval process of your CPA, and do you have any resources you utilized? So as I mentioned, we have an anemia clinic for managing patients with anemia of CKD within the transplant clinic, and that's all transplant organs, just adults. And we were able to develop ours, I guess, off of a similar clinic. So my advice would be, if you have a similar clinic somewhere nearby or within your hospital, to start there as a place to look and kind of start developing yours. One of our transplant pharmacists works at the kidney clinic, and she had an anemia clinic there. We used that as sort of our baseline model, but modified it to apply to transplant recipients. We were able to get one of the transplant nephrologists on board, and so he was also involved with creating the CPA. We reviewed the literature that existed regarding management of ESAs within anemia patients. And so based on all of that, we put together the actual CPA, or protocol that we call it, that we would practice within. And then we had to do the normal approval process that many of you would probably have to do. There was a lot of kind of like boards we had to go through as far as getting ambulatory approval and just P&T approval and that sort of thing. Our manager was very helpful in helping us kind of guide through where we needed to go with that. And then any resources that I felt were particularly valuable was, again, finding someone who had done something similar and using that as like a springboard to start off your clinic from. So even if you don't have someone within your own center, transplant pharmacy is a sort of small community. You can probably find someone within the community that's done something that you're looking to do and could give you some advice. I don't know if Laura's microphone is working now. She might have a few things to add in as well.
Can you hear me now? Great. My name is Laura Mincemoyer. I'm the clinical pharmacist practitioner in the abdominal transplant clinics at UNC. And I work in both kidney and liver transplant clinics. I see patients primarily during the first year after their transplant and help manage not only their immunosuppression, but other comorbid disease states as well. What I love most about my role is my ability to develop relationships with patients and help manage their complex medication issues, as well as working with a great interdisciplinary team. It's really rewarding, and I really enjoy coming to work each day. So in regards to my clinical pharmacist practitioner protocol, I was fortunate to inherit a pretty comprehensive CPA from my predecessor, but it's pretty all-encompassing. In the state of North Carolina, pharmacists can be licensed as clinical pharmacist practitioners with the Board of Pharmacy. And as long as there's a protocol approved by your supervising physicians, we can prescribe under with a variable or a significant number of disease states and labs and medications. And similar to what Jillian had said, we have an extensive approval process with the institution to get that approved.
All right, so our second question is going to be for Janice and May. So how did you get interdisciplinary buy-in for your CPA?
Here at UCSD, we are a teaching facility. So basically they're used to having pharmacists on the team, and they've become very dependent on having pharmacists on their team. And so it was just a matter of time where we could demonstrate how much work we could save them by entering the orders, and we're already doing the recommendations and the dose adjustments. So basically just meeting with the medical and surgical directors, explaining what the CPA was. And then many of our faculty are new to UCSD and maybe didn't have a pharmacist that was this involved in the care. But I've gotten nothing but positive remarks about our workflow and our integration into the team.
May, we can't hear you.
Can you hear me now?
Yeah.
All right, good. Sorry. I was just saying sorry about the technical difficulties. That's a problem with working remote. But anyway, so in regards to the CPA, this is sort of like a novel antiviral stewardship initiative where we provide monitoring and hopefully quality improvement for the care of CMV in our transplant patients that are enrolled in the program. So the question was, what prompted this, or how did you get support? So like most initiatives, especially quality improvement, it came out of a problem. So we noticed pretty much after the advent of testing for ganciclovir resistance that our numbers were increasing, every year. So in 2016, we had something like 13 patients with ganciclovir resistant CMV who were being admitted and, recurrence and whatnot to the hospital. And the transplant division said, this is a real problem. And we thought, well, we can really provide some benefit. And my background training was infectious disease back in the early 2000s during the rise of antimicrobial stewardship. So I do have some background in that topic. And we started it as a resident project, and it really just grew from there. So since there was a problem that needed to be fixed and, we were volunteering to fix it, the buy-in was fairly simple. As far as the buy-in for, our ideas on how to fix it when it was an actual patient. Sometimes that took a little getting used to by the teams, but our very first step for getting this together and advertising it to the teams was to create a monitoring protocol that had buy-in from transplant surgery, transplant hepatology, transplant nephrology. So all of the division directors had a chance to read it, had a chance to agree to our practices. And so that really worked well to avoid any, conflict.
So our next question is going to be for Jillian C and Jillian F. Could you describe any barriers or resistance that you encountered when implementing your CPA? And also, is there anything else that you wish you had known prior to development or implementation?
Yeah, I can start with that. So when I joined the team, the CPA was already in existence quite extensively for our abdominal transplant recipients, not so much with the cardiothoracic patient population. So really in the time that I've joined this team for the past 5 years, that's where we've seen a lot of growth. And I would say we, interestingly enough, haven't met a lot of resistance in terms of providers not wanting us to be involved or not wanting to have the collaborative practice in place. It was almost the opposite. I think the providers saw that what was going on at the abdominal side, and they were a little envious, and they wanted a pharmacist involved in all aspects of the transplant care as well. But every team dynamic is a little bit different. The team structure is a little bit different. And one of the things that's really important, I think, to the success of the CPA is making sure that it's sustainable and it's something that can happen from day to day, whether it's Monday through Friday or 7 days a week. And we've had providers who have really wanted us to do quite a bit more than maybe what we're comfortable with in the scope of our practice. So we actually had to be on the kind of the opposite end and say, we want to take a step back and make sure that whatever is in our CPA is something we can do every single day for you. And if that means limiting what drugs that involves initially, then we were more comfortable with that. So we met a little bit of resistance there because I think they were very eager to get us involved in lots of aspects of care, which isn't a bad problem to have necessarily.
And so I would say at UW with our anemia clinic, we didn't have a ton of barriers. We had done a good job of identifying that the transplant coordinators were having a hard time really managing patients' anemia in the outpatient setting. And like I said, we already had a similar clinic at the kidney clinic that had done well. A few barriers that we did, I guess, encounter, surprisingly, were some patient barriers. There are a few patients that had been transplant patients for a long time and were sort of confused on how the pharmacist was going to now be taking over their role. So we had to do a little bit of explaining that to patients and that their transplant provider had okayed and signed off on them doing that. Other barriers I guess we got were that at UW, the transplant coordinators do a lot of managing of patients. And so sometimes they didn't really want to follow the route of getting the CPA initiated for their patient, which is technically they have to put an order in that the physician had signed off on saying that they were referring to them to our clinic. So we had to do some education on that, making sure that they were following that protocol so that it would be legally sound and not just sending patients our way without getting the doctor signed off on it. And then things I wish we had known. I guess one of the things that we have ran into is just the success of our clinic. We did not really get any additional hours to manage this clinic. It's just built into our transplant clinic pharmacist role. And as a result of that, as the clinic had gotten more successful, just finding ways to make sure that we're managing all of the patients and keeping up with them is a little bit harder. So if there's any way in the beginning to have carved out some FTE to go along with implementing the CPA, I would encourage that, because now we've been doing it for 10 years. And so it's hard to justify. We've tried, but to get more FTE when we've already been doing it, to get the department to give us more FTE to do something we're already doing. So had we been able to get more FTE to support it on the front end, I think would have been helpful.
All right, our next question is going to be for Laura and Janice. What prescriptive privileges do you guys have, and are you able to order any labs independently?
So with my CPA, as I mentioned, it's quite broad. Outlined in my CPA basically states that I can prescribe for a variety of different disease states for any of the patients that are seen by any of my supervising physicians. So for me, it's things from immunosuppression and opportunistic infectious prophylaxis to hypertension, pain, and diabetes. So mine's pretty comprehensive. And then I am able to order labs independently. And those specific labs that I'm authorized to order are outlined in my CPA. I don't know if Janice has anything different.
We have a very similar structure to our CPA. It's broad. So basically, we can manage and modify any medication related to a variety of disease states. So immunosuppression, opportunistic infection prophylaxis, hypertension, or we have a lot of Hep C organs, any of their hepatitis, diabetes, if I didn't mention that. So basically, anything related to their transplant, we can initiate or modify. Similarly, with labs, we can order any lab-related, place any lab-related orders, medication-related orders, such as like fluconazole levels and whatnot. It's pretty broad.
Next question that we have is for May and Jillian C. What certifications or credentialing did you have to obtain in order to participate in the collaborative practice? And do you have to do anything annually to maintain your certification?
So I can start. It's easy for us because it's really a novel practice entirely that hasn't really been done before. So there's really no certification and credentialing required, and therefore nothing to maintain. It's pretty much all done via communication with the transplant team. We're a consult service, so they can certainly choose to not follow our recommendations, just like any antimicrobial stewardship you might have at your institution. However, we do try to be very hands-on with the stewardship practices. So we do work with the coordinators to make sure labs are ordered correctly and prescribe the valsite or stop the valsite depending on what's required, do test claims for letermovir, or suggest immunosuppressive adjustment in the setting of treatment. So we try to take it one step further than maybe your classic antimicrobial stewardship, where you would leave a note in the chart that says we recommend this. But yeah, we don't have any credentialing that is required. Maybe we should invent some, Jillian. Then we can be consultants.
At the University of Maryland, I was really impressed and a little surprised actually, when I started here, because all of our pharmacists of our solid organ transplant group are on our collaborative practice agreement. We had a pretty intense training, more an orientation, more than I think I was expecting initially out of residency. For probably about the first 3 months of my time at Maryland, with a part of the team to build up that relationship with the other providers, become very familiar with the collaborative practice agreement, and really familiar with the practice at Maryland, because as we know, every transplant center is a little bit different. And after about 3 months, I took a collaborative practice exam. It's specific to our institution. We've created it amongst ourselves. But essentially every hire that we've had within our group has taken a version of that collaborative practice exam. It's not something that we have to continue to take. And certainly with any new positions or new hires that we have, in addition to obviously them passing this collaborative practice agreement, certainly we are looking for providers and pharmacists who are transplant trained and kind of have a similar background in terms of the involvement of the pharmacist from their residency training or whatever institution they came from, so that they are prepared for the involvement of the pharmacist at Maryland. And it's been interesting, actually, because our residents are also involved and a part of our collaborative practice agreement. And so over the years, we have modified how we've gotten them involved. And we now take kind of a tiered exam approach where we have multiple exams for different organs, as well as different aspects of the care. So ranging from maintenance immunosuppression and opportunistic infection prophylaxis, maybe a little bit earlier in the resident year. And then as they become more familiar and they are exposed to more complexities of the patient population, they'll take a collaborative practice exam that focuses more on treatment of rejection, treatment of more complex infectious disease complications. So this way they're getting exposed throughout the first half of the year rather than waiting towards the mid to second half of the year.
Great, thank you. So the next question that we have is for Jillian F. and Laura. How do you ensure that you guys have adequate coverage at your institution, and do you have 24/7 pharmacist support?
Oops, sorry. So for our CPA, it's anemia management. So that's really not like a urgent matter that needs to be addressed immediately. The way that we have coverage for that is Monday through Friday, our transplant clinic pharmacist responds to any inbox messages or pages about anemia clinic. And so that's, like I said, Monday through Friday, 8 to 4:30. Whoever is working transplant technically can cover the inbox, and if there's any messages, or we could get covered by our pager. We don't have 24/7 transplant pharmacist coverage. We have about 7 a.m. till 10 p.m. transplant pharmacist coverage most days of the week, usually Monday through Friday. And then on the weekends, there's a transplant pharmacist from 7 to 3:30, and there may or may not be one in the evening. So again, for ours, you don't really need it, but we are available via pager most times of the day.
At UNC, we are also just Monday through Friday. We don't have 24/7 pharmacist support. So I'm the only one in the abdominal transplant clinic with a CPA, but my cardiothoracic counterpart also has a CPA that's almost identical to mine. And we have the same supervising physician over the entire transplant program. So when one of us is off, the other typically covers. In the event when we are both out, or if she was out on leave, we do have a float pharmacist that can cover, but she doesn't have a CPA within our individual clinics, so she can just provide recommendations for changes or initiation in therapy, and actually can't send prescriptions herself.
Okay, for our next question, we're going to ask Jillian F. and May. Do you guys capture any metrics as part of your CPA involvement? And also, have you looked retrospectively at your outcomes? And if so, how long after initiating did you assess them?
So for the anemia clinic, we had really our two goals were time within range for hemoglobin, and then iron studies within goals. So when we initiated the clinic back in 2010, we collected those prior to initiation of the CPA, and then I collected them 1 year afterwards. We had good success at that time, and we didn't really continue to follow them on an annual basis. Over time, though, we have modified and collected some other outcomes. Part of our anemia clinic, we have the patients that come in person to the transplant clinic in Madison, but we also remotely manage some of those patients who live in more rural areas. And more recently, we started looking at prescription capture rate, because one of our goals was to have these patients fill their medications at the UW specialty pharmacy to try and increase some revenue and potentially use that as justification for more pharmacist FTE. So we currently have an intern that's collecting some of that data to see how much revenue we had generated from the second part of the anemia CPA, which was ambulatory management. So I guess to summarize, we haven't currently had set time points where we've looked back retrospectively to assess our outcomes. We did in the beginning. We showed good outcomes, and that seemed to be satisfactory. We have talked about doing it again maybe in the coming year or two when we have another intern or learner who might be interested, just to make sure that we're still staying on kind of target with managing these patients and see if there's anything we need to change. But so I guess that's that answer. I think May will have more to say about the CMV metrics, so I'll pass it over to her.
Yeah, well, again, the whole thing arose out of rates of ganciclovir resistance and all the costs associated with that and the terrible outcomes. So originally we had done sort of a quality improvement review of the literature, kind of manuscript about how our patients were doing, and they were doing really terrible, and we were trying to figure out like what the best regimen for suppression and reduction of recurrence was. And out of that paper, I believe it was from 2016 or 17, we really found like what we should be doing is preventing it altogether, you know, because the outcomes are so bad. So once we started as a resident project, this antiviral stewardship outreach, basically everything we were doing didn't really have, I mean, there's guidelines, of course, for the management of CMV, but as far as the like minute choices that you make in treatment, there really is not that much literature to guide your choices and, you know, the stepwise process. So we've actually had a lot of, you know, quality improvement initiatives that have come out of the clinic, just more so than measuring metrics, but just to help guide us on how to manage these patients, because there's a lot of questions that have not been answered. Also throughout, and this is true of all these projects that arise out of, or these CPAs that arise out of a resident project, initially you have a whole, you know, person who is working on this, you know, outside of business hours, and then they end up leaving to get a job, and then you have this program that is in effect, and then the people who are currently employed are expected to continue it. So we knew throughout, you know, this is a big time commitment, and we're going to have to capture what we do and use it to make a portfolio to try to get more FTE support. So we've done that throughout, you know, measuring rates of ganciclovir resistance, of course, which luckily have gone down, but also tried to, you know, document the shift from, like, initially we were following mostly people who were being treated for CMV. We instituted, you know, sort of a surveillance program, and now most of our patients are surveillance. So theoretically, we've reduced the amount of patients who require treatment, and tried to keep all of these in a portfolio we can use to take to management to say, you know, look at all these good things we're doing. We need some more support. So yes, we've looked retrospectively, like extensively, at many different aspects of the care we're providing. And I believe it's really improved what we do, because we have now evidence to support our decision-making process.
Very good. So let's go to our next question, and this is going to be for all panelists. So has the development of your collaborative practice protocols or conventional methods for making interventions resulted in any new revenue for your department? And are you currently billing for your services?
I'm happy to start this one. We are not billing for our services at my institution, though maybe one day we will. That would be wonderful. Our center has looked more at cost savings, particularly on the inpatient side of the pharmacist involvement through a collaborative practice agreement. But as I mentioned, our collaborative practice agreement also extends into select clinics. Right now, one clinic is more of our kind of acute care, freshly transplanted kidney and pancreas clinic, though we're hoping to expand into more areas. And in that clinic, we are responsible still for the immunosuppression adjustments under the collaborative practice agreement. And then by being in that different setting, it kind of switched from cost savings to revenue generation, because we're able to also, as we make these dose changes and we're adjusting their tacrolimus doses, the pharmacist is the one who's also communicating that change to the patient, and we're also the one who is starting the conversation about which pharmacy are you going to fill your medications with long term. And so we're starting the conversation about using our pharmacy services at the University of Maryland, explaining what services we provide that are special to our transplant patients that they may not receive at other local pharmacies. And while we haven't formally evaluated it, I do really believe that it contributes to the retention of these prescriptions and lots of revenue generation.
I can take over. At UNC, we, similar to what Jillian said, we end up increasing prescription capture to our specialty pharmacy. I think historically that had been looked at for generation of new FTEs, although over the past couple of years that measure hasn't been utilized. But that does generate significant revenue. Regarding my individual services at clinic, we are not, recognized providers, unfortunately, through Medicare. So we're not billing for our services as an APP, but we do increase the facility fee that's billed for with pharmacist involvement. So at this point, we're just using the facility fee.
I can go next. So for our anemia,
go ahead, Jillian.
For our anemia, all right. For our anemia one, as I said, we were trying to look at prescription capture rate at our specialty pharmacy, but that's a little bit difficult because some of that's driven by insurance payers, and some insurance requires patients to fill through a specialty pharmacy. So currently, when we had our intern look back, we had not really made much revenue, unfortunately. So we're currently trying to see if there's more patients that if we had captured their prescriptions at our pharmacy, if we would be able to increase our revenue and try and get pharmacists. Sort of in the beginning, we were a little bit like, where do you want your prescription? We didn't really push our pharmacy that much. And so if there's a potential for more revenue that comes out of this project, then we'll probably start doing that. And then billing for services, similar to what Laura said, we can't really bill. We're able to bill for like an injection fee and a facility fee. So within the transplant clinic, that's increasing some revenue, but nothing specific to pharmacy.
At UCSD, we are also looking at both cost savings and cost revenue. So maybe a couple of years ago, we started having transplant pharmacists cover the weekend, so it would facilitate weekend discharges. And so the team and hospital looked at like the number of days saved on the admission. We were able to fund like 1 to 2 pharmacists based on that cost savings. We also have a specialty pharmacy, and so we do encourage our transplant patients to continue to use their services. And so we do look at revenue from anything related to transplant. So mostly immunosuppression, but as you know, like the antifungals are pretty pricey, as well as the new diabetic medications. And so we've been able to also justify revenue from prescriptions sent to our UCSD specialty pharmacy. We also don't bill for our services except for this facility fee when needed.
Yeah, and then I just echo everything everyone else said. It's cost avoidance, and cost avoidance is really tough to put into a portfolio for management to say you need more support. So if anyone figures out how to bill for it, how to generate revenue, email us.
Thank you so much for your insight. Let's go to the next question, and this is going to be for Janice and May. So how do you keep your collaborative practice focused to make sure you're in compliance with the law, and is your CPA being audited?
So our CPA is managed by our clinical supervisors. He manages all of the ambulatory specialty pharmacists, as well as the inpatient abdominal transplant pharmacists. So every 2 years, I think, is when we need to renew and get new signatures. So I let him take care of that, and I just make sure everything's signed. We don't get audited by the Board of Pharmacy, but if JCO did come or CMS, then we are able to provide that documentation.
Yeah, and it's not not too pertinent to antimicrobial stewardship, but you know, it's all of our orders are verbal from physicians, so there's and otherwise it's new, so there's no laws that extend to it. Certainly, you know, there are regulatory bodies that make sure that you are doing antimicrobial stewardship on the whole at your institution. However, antimicrobial stewardship in the immunocompromised host is, again, a sort of new concept. Originally, they were excluded from those initiatives, and therefore, you know, not something that is being audited at this time.
Thank you so much. And our next question is going to be for Jillian, C, and Janice. Do you have any advice for initiating conversations with providers about expanding pharmacist involvement in transplant-related practices?
Yeah, definitely within our transplant teams, we've seen a fair amount of turnover within our providers, both like our surgical providers and our medical providers. And so every time we have a new surgeon join our team, or a new nephrologist or cardiologist, whatever the specialty is, we sit down with them and explain what their existing services are. I think it's important to get a good sense of, for providers who are coming from other institutions to your institution, see how pharmacists were involved in their previous institution. If they came from an institution where they didn't have a pharmacist actively involved in managing these orders, or have a CPA at all, it might be a little bit of a culture shift for them. And certainly you want to make sure you get their buy-in. So I think explaining, what we have in place, how it works, how it benefits both the patients and then the providers by, freeing up some provider time and making sure they're able to focus on maybe, things that pharmacists cannot focus on, I think is really, really important. Some providers might not know what a collaborative practice agreement is. I've had physicians say, "What's a CPA to me?" So, I think to a pharmacist, we talk about that all the time. Medication therapy management is such a hot topic in pharmacy, and advancing and practicing at the top of our license. But for some providers outside of pharmacy, they may not be as familiar with it. So just making sure they understand what you're trying to achieve, I think helps get their buy-in quite a bit.
I think for me, echoing everything that Jillian said, but also presenting and identifying a problem and then coming up with a solution for them. So for instance, we were spending a lot of time managing diabetes within our perioperative clinics, which was taking up time, and room turnover was slow. And so I proposed that we take those difficult patients outside of that clinic and start a transplant diabetes clinic. And same with infectious disease. There was a need for pharmacist support. So basically we have just suggested that whenever there's a complex patient, to consult us and we can assist with that. So basically just coming up with a solution to the problems that you guys see from day to day.
Thank you, that's really helpful. All right, and then the next question that we have is for all panelists. So what is the most rewarding part of your CPA?
I'll go first. I think part of it is efficiency. So with having the ability to sign orders and order anything that I need from a pharmacist standpoint has helped with efficiency. So rather than talking to the doctor, making a recommendation, and then having them enter the orders, it's just been nice to straight up do it and call the patients directly.
I think for me, and I kind of alluded to this earlier when I said what I like most about my job, is for our collaborative practice agreement at my center, it's very focused on immunosuppression and anti-infective prophylaxis, as well as a couple other medications, but that's really the bread and butter of what our CPA is. And those are some of the most critical aspects to patient care. And so because we are so intimately involved with those medications, we're a part of all of the discussions about immunosuppression and anti-infective prophylaxis and treatment of opportunistic infections. It's not very common for us to come into work and not get contacted by the team immediately about, treating a rejection or induction plans. And so it really allows us to be a very integral member of the team for sure.
Similar to what Janice said. Oh, okay, go ahead.
No, go ahead, Laura.
Okay. Similar to what Janice said, I appreciate the independence and ability to make changes without asking for permission. As we all know, there's a lot of things that can be that can come up in between visits. So a lot of our coordinators will utilize me in between visits, whether it's to adjust antihypertensives, adjust diabetes medications. It just allows us to take some of the heat off of the physicians and optimize care in between visits.
I would say for our anemia clinic, one of the things that I thought was rewarding is following these patients on a regular interval. We've had patients that we see every month or every other month for 10 years since we started the clinic. And I feel like you get to really know the patient and learn about them, and they learn about you and develop more of a patient-provider relationship than we do oftentimes like on the inpatient setting, because those patients are coming in and out. So that's been pretty rewarding for me, just getting to learn more about our patients and connect in that way. And then also I would say kind of becoming a specialist in the area that your CPA covers. So when we started the anemia clinic, we weren't really that involved in anemia management, but now we get a lot of questions from providers even about other patients we're not caring for within the CPA, just for our recommendations for managing anemia, because we've kind of become recognized as the group within the transplant department that manages anemia. So I think that's also been rewarding.
Yeah, it is very rewarding to be able to follow people long term and kind of see, what changes you've done that have improved their care. I totally agree with that, Jillian. And we've seen that in CMV as well. Since we started in 2018, unfortunately, you guys probably know and have seen in your own practice that some of these infections are very long term, especially in the outpatient setting. You'll be treating patients with valsite, unable to clear their viremia for like over a year from their initial diagnosis. So that's really cool. And then also, I think the most rewarding part is the quality improvement. Like, you wouldn't think something that has been so extensively studied, that has best practices, guidelines to help guide use, really would need a whole lot of quality improvement. But I think, the understanding of its meaning in all clinical situations is not entirely clear or hasn't been completely elucidated. So it's a little bit of a journey of discovery, and you get to think about, well, maybe if I figure this out, this will improve care for not just my patients, but transplant patients across the US and across the world even.
Thank you, everyone. So I think at this time, we'll go ahead and take some questions from the audience. And any one of you can answer these questions. So the first question that we have is, did you have to include any specific wording to allow learners, such as residents or students, to assist with your work under the CPA?
For ours, we did not. We just have them co-sign everything. So our wording is people trained within the transplant clinic, I think. So residents apply to that. If we have students or anything, they would have to co-sign their notes to a pharmacist. And obviously they can't order prescriptions or anything. So the pharmacist would ultimately do that. So we don't have any specific wording about students within our anemia protocol.
I think I mentioned this a little bit earlier. Students are not involved in our CPA, but our two PGY2 transplant residents are. We kept the wording a little vague because obviously they change every year, and we update our CPA every 2 years. But they are included. And I also mentioned that initially our CPA, they did not take the collaborative practice exam until about the midpoint of their PGY2 year. And as a residency program, we wanted to get them involved and independent a little bit sooner. And that's why we came up with more of a tiered CPA approach for our learners. But it is specific to the PGY2 residents because they're licensed pharmacists.
Thank you, Julian F. and Julian C. The next question that we have from the audience, and again, if anyone is willing to comment on this, what medications are currently involved in your existing CPA?
I'll go first. We don't have any listed medicines. We just have a list of the disease states that we can manage. So like I said, off the top of my head, immunosuppression, opportunistic infections, any infection, blood pressure, cholesterol, diabetes, constipation. Pretty vague.
On the flip side, I would say ours is very specific. We only manage ESA therapy and iron therapy, including IV iron. So we can order IV iron and then any ESAs either to be given within the clinic or to be ordered for prescription for the patient to fill as an outpatient.
Similar to Janice, mine is pretty broad. We have covered disease states as well as individual therapeutic classes that are all listed out in my CPA.
Similar to Jillian, our CPA is very specific, but it does include all aspects of the immunosuppression. So it includes induction. We don't order induction for the doses that are given in the operating room, but we do manage all of the orders that are post-op. It includes their maintenance immunosuppression, so calcineurin inhibitors, the mTOR inhibitors, antimetabolites, prednisone. It does include belatacept. So if we do have patients that are on belatacept, we're able to manage their orders, opportunistic infection prophylaxis and treatment of those infections as well. And we also have we include management of complications of immunosuppression, but they're very specific. So for example, we have a alemtuzumab-induced neutropenia protocol that allows us to order GCSF as well as all labs that are associated with that. But it is very clearly spelled out in our document what agents are under our purview.
Thank you very much for your answers. And another question that we have from the audience is regarding kind of the support that you get. So for those of you who may not have a team of pharmacists, how do you support your job when you're not there? So if you're out on vacation or you're taking some time off, who covers you?
At our hospital, the pharmacists are heavily relied on, and so we actually have float pharmacists that cover vacation and days off.
So I'll speak a little bit on behalf of May because she is our primary CMV clinic pharmacist, and then I kind of help out. But I would say she ends up going above and beyond and just being available even the times that she's not working. So unfortunately, I think sometimes with these protocols, if you are really good at what you do, which she is, then people want to talk to you at all hours of the day. So even if I'm covering the CMV clinic and have a question, she is readily available via text message. And so I bug her many times when she is not working. And so that is something to consider, how do you cut off caring for patients when you're not there? And I think if you are passionate about what you do, that's very difficult. And it's very evident that May's passionate about that clinic because providers text her or send her chat messages, and she answers them really at any time, even if she's at the park with her kids or doing something, she always answers. So if you're looking at creating a CPA, that's something to consider of having defined hours, or is it something that you're willing to kind of be available at all times?
Yeah, that is true. And part of it too is, like how Jillian was saying with the anemia clinic, we follow these patients long term, we have a relationship with them, and you really care about their outcomes. You don't want to see some mismanagement, and even like so much of it is gray. It's hard to know like what is the correct path versus, there could be multiple correct answers, I suppose. So you have to weigh all the risks and benefits of each choice, and they can have pretty significant outcomes. In fact, we did have a patient who, was resumed during the treatment of his CMV on mycophenolate for only 2 weeks and ended up developing resistance. So, not being involved in that one, clinic appointment, and then you have to deal with the fallout of that, and, all the kind of regret you have with, oh, what could I have done differently to have elicited a better outcome for this patient? Because, you talk to him on the phone every week for like 6 months. So, you really get quite invested.
All right, we just have a couple minutes left. So for our last question, if you could give one suggestion to someone who's looking to start a CPA at their institution, what would you recommend? Or what insight would you share with them?
Ask for more time than you think you need.
Yeah, I would second that, is to try and guess what support you're going to need from management and ask for that up front. And like May said, probably overestimate it, because as your service becomes more popular, you're going to have more and more patients than maybe you had initiated or initially planned for. And if you don't have the support built in, then your outcomes will struggle, or your clinic might struggle, not because you're not able to care for the patients, but you just don't have the support to.
I would also say, there's certainly times where we'll take unique approaches, but I would say you don't always have to reinvent the wheel. And so reaching out to centers that are already have established CPAs, so you can learn from their mistakes and their successes, I think is really important. Sending out a message on the PRN. I know when I get lots of responses. And so if you're looking to start something like this, try to, solicit feedback from people who have done it well, or maybe haven't done it well, and why it didn't work for their center.
I would recommend making sure that whatever new CPA you implement, that you're able to track your metrics, because at some point, whether you're asking for additional FTE resources, it's nice to show what you're doing, and don't be afraid to utilize learner resources to do so.
Well, thank you, everyone. This was a great discussion on CPAs and protocols. Again, thank you very much for your time and your insight regarding your institutional practices and the care that you provide to your patients. And for everybody who attended the webinar, thank you for your time. And we hope that you can join us next month for another webinar through ACCP. And with that, we will conclude our presentation.